Morning, everyone. So the topic of my presentation today is intravitreal chemotherapy for retinoblastoma, slaughter the seeds. We have no financial interest. So coming to a brief introduction, vitreous seeds provides a very specific therapeutic challenge in the management of retinoblastoma, as it is refractive to the conventional intravenous chemotherapy. Rees and Ellsworth, in their initial classification, classified eyes with vitreous seeds to be 5B, which was very unfavorable for globe salvage. And even with external beam radiotherapy, a globe salvage percentage of only around 50% has been reported, with its complications such as cataract, secondary malignancy, as well as orbital growth retardation. Intravitreal chemotherapy, however, has emerged to be a useful adjunct in our armamentarium of management of vitreous seeds. So the aim of this presentation is to discuss our preliminary data about the outcome of management of recalcitrant vitreous seeds with intravitreal chemotherapy in retinoblastoma and its associated complications. So it was a retrospective review of records of patients who received intravitreal chemotherapy between the years of 2010 and 2019. All patients were classified as per the International Classification of Retinoblastoma by Shields et al. Seeds were classified into dust, cloud, or sphere as given by the Francis Munier group, as was the regression patterns, type 0 being complete disappearance, type 1 being refractile or calcified, type 2 being amorphous, and type 3 being a combination of the two. Patients with at least 5 months of follow-up were included in the study. We can see in the top image that there's presence of this large cloud of vitreous seeds, whereas in the lower image, we can see the presence of these small spheres of vitreous seeds, along with like diffuse dust. So coming to our results, we had 9 eyes of 9 patients, 5 were male and 4 were female. 3 patients were unilateral RV and 6 were bilateral presentation, while the mean age of presentation was 27 months. 1 eye was group B on presentation, which on follow-up on intravenous chemotherapy developed vitreous seeds. 1 eye was group C, and 7 eyes were group D. 8 patients of these received primary intravenous chemotherapy, 2 to 6 cycles. 1 patient received primary intraarterial chemotherapy, and 3 received secondary intraarterial chemotherapy. Local therapy was as and when required. Vitreous seeds was 3 eyes had dust, 4 eyes had cloud, and 2 were sphere. All eyes received intravitreal melphalan, topotecan, or a combination of these using a 31-gauge syringe with triple freeze, slow-thaw cryotherapy at the injection site. A total of 35 injections were given with a mean of 3.8 per patient. Only 2 patients received melphalan, 4 received only topotecan, and 3 patients received melphalan and topotecan as a combination. The dose was 20 to 30 micrograms per drug per injection. A mean total dose of 60 micrograms were given per patient, and a mean total dose of 90 micrograms was given per patient. Mean follow-up was 13.8 months. The regression pattern was seen in 5 patients. 1 had complete disappearance, 3 had type 1 regression, and 1 had type 3. None of the patients had extraocular splenomegastasis. We can see in the images, this is an image of presence of these small seeds with diffuse dust. This patient received 6 injections of intravitreal chemotherapy and was left with just these small calcified deposits. We had complications in 3 patients. 2 had RPE changes, and 1 had iris atrophy, iris bombay, hypotony, and cataract. In conclusion, intravitreal chemotherapy is a useful treatment modality for recalcitrant vitreous seeds of retinoblastoma. Our reported resolution was 56% in eyes with seeds, whereas in literature it's 81 to 100%. These are our preliminary results. These are early days for us. Complications were seen only in those patients who received intravitreal melphalan, and topotecan has recently become more in vogue and has been reported to be non-toxic to retinol ARG studies and has a high efficacy for management of vitreous seeds. It probably makes sense to shift over to isolated intravitreal topotecan for management of such seeds. These are my references, and I would like to thank my co-authors, Advanced Eye Center, as well as AIOS for giving me the opportunity to present at this podium. Thank you.
Thank you, Dr. Uday. I am asking a very critical question here. Now, you see there is a posterior pole retinoblastoma, which can have a posterior vitreous seeds, it can have a mid vitreous seeds, it can have an anterior vitreous seeds. How you quantify a vitreous seed when you choose for a intravitreal injection? And second point is that I'm leaving the group D retinoblastoma. Okay, how you answer B or C group retinoblastoma?
The posterior vitreous seeds, which would be probably present close to the retina versus the mid or the anterior vitreous seeds, if these seeds were on follow-up, we could see that on intravenous chemotherapy, they were not responding. These became candidates for us to add intravitreal plus minus intraarterial chemotherapy. The addition of intraarterial chemotherapy was based on a cost-effective basis for the patient. Irrespective of the location, anterior, mid, or posterior vitreous, all these patients were given a trial of intravitreal chemotherapy till such time that we noticed that the seeds were either not responding, they were increasing in size, or this patient warranted to go ahead with a more definitive treatment of enucleation. Regarding the group B, sir, this patient was a 3-month-old child who was initially given 3 intravenous chemotherapy, but from the isolated group B lesion, there was a break into the vitreous cavity, and this patient developed vitreous seeds, for which she was given intravitreal chemotherapy as an adjunct to systemic chemotherapy.